Hi, my name is Ryan Plank. I'm an orthopedic surgeon with Lakeshore Bone and Joint. I've been there since 2011, I think. I do general orthopedics with a focus in sports medicine, subspecialty training in sports medicine. So I'm going to talk about specifically rotator cuff injuries. I think Dr. Guzzo is going to talk about instability. The reason I'm talking about shoulder injuries is because many reasons, but they do represent a significant amount of the overall lost time work injury claims, about 15% depending on which study you look at. And what's interesting about that is that in a decade or so where there's been a focus on workplace safety and injury prevention, a lot of the extremities have seen declines in injuries, whereas the upper extremity, the arm and the shoulder, have not. Why is that? Well, there's probably lots of reasons. Part of that is people are working longer. And specifically with rotator cuff type injuries, you know, older people as they age and are still trying to do active heavy lifting and things tend to be more prone to injury. A big portion of it is over imaging, meaning a rush to get MRIs on every single shoulder injury that happens. Here's a chart just demonstrating what I just talked about. The different colors represent different years, and if you look at most of the body parts, you can see that they've been trending down. When you look at the arm and the shoulder, you can see that they've stayed pretty much constant. In addition, if you look at this chart, this demonstrates that although shoulder injuries may not represent the largest number of work injuries, when you look at actually time away from work, they are right up there at the top as far as median time away from work when someone does have a shoulder injury. Again, which makes this an important topic and a reason the treatment of these injuries is important. So type of shoulder injuries, we're going to talk about rotator cuff tears. That's just one type of shoulder injury. There's also slab tears that Dr. Guzzo may get into, shoulder dislocations, which are labral tears and instability, AC joint injuries, proximal biceps rupture. The notion of impingement, which is typically not really an injury, but is related in a way to rotator cuff tears, as well as proximal humerus fractures. So when we look at the rotator cuff is tendons arising from four different muscles. The supraspinatus, which is the primary abductor of the shoulder. This infraspinatus, which is an external rotator. The teres minor, which is a small muscle in the back that's also an external rotator. And the subscapularis, which is also a primary internal rotator of the shoulder. Besides the rotation and the motion of the shoulder, one of the most common functions of the rotator cuff is that it depresses the humeral head within the shoulder joint. And that'll become more apparent as we look at further in this lecture when we look at what happens if you don't have your rotator cuff repaired. Again, here's a schematic involving the anatomy. You can see that the supraspinatus is typically the rotator cuff muscle that sits more superior in the shoulder within the supraspinatus fossa. The infraspinatus and the teres minor are around the back of the scapula here. The subscapularis is really the only rotator cuff muscle that's in the front of the shoulder. And you can see that the supraspinatus, infraspinatus attach on the greater tuberosity. Subscapularis attaches on the lesser tuberosity, which allows it to provide internal rotation. Here's an arthroscopic picture of a healthy rotator cuff. This is from inside the joint. The white at the bottom is the articular cartilage of the humerus, and you can see that the articular margin, there's no separation between the rotator cuff tendon. Yes, go ahead.
Going back a slide.
Yeah.
Which exercise would be the best to prevent having a rotator cuff tear?
Well, I don't know that you can truly prevent a rotator cuff tear, but you can, there's a series of multiple exercises. I mean, abduction, forward flexion, there's extra rotation exercises, typically low weight, high repetition, that kind of thing. Here's another arthroscopic picture of a healthy rotator cuff and its attachment. Again, you can see that there's no separation between the articular margin of the humeral head and the rotator cuff tendon where it attaches. Here's another healthy rotator cuff. This is now viewing from above the rotator cuff. We're now in the subacromial space looking down at the rotator cuff. And again, if you can see there's no holes in the tendon, you'd be looking for the shoulder joint or a hole letting you see down into the shoulder joint if there was a rotator cuff tear. Here's a radiograph, a normal shoulder X-ray. You can see that this is the humerus, this is the glenoid, this is the acromion, which sits on top. you can see that there's a space between the two. This is where your rotator cuff runs and attaches out here on your greater tuberosity. When we look at the anatomy on the MRI, again, here's your glenoid, which is the shoulder socket. Here's your humeral head. This is fluid in the joint. This is your supraspinatus, which is your most commonly injured rotator cuff tendon. The tendon coming out here and attaching on the greater tuberosity. Again, the rotator cuff tendon running in this space between the superior aspect of the humeral head and the acromion. So when it comes to rotator cuff injuries, you can break them down. I mean, you can see there's a large number of rotator cuff tears each year. You can break them largely into acute tears and degenerative tears. I would argue that most commonly patients I see, work comp or non-work comp, are typically patients that have probably had some sort of chronic rotator cuff disease, impingement, tendonitis, and the tear is really more of an acute on chronic type of situation. Signs and symptoms, I mean, obviously the fall or the patient that feels a pop, those are the most obvious ones, but other signs and symptoms would be pain at rest or night, pain with lifting or lowering the arm, especially through the mid-range, weakness, crepitus, and lateral arm pain. I can't tell you how many people come to me complaining with the chief complaint of arm pain when in reality it's a rotator cuff. Non-surgical treatment, obviously, if someone's got a full thickness rotator cuff tear, typically there's not a big role of non-operative management. But with partial rotator cuff tears, impingement, rotator cuff disease, rotator cuff pain, we typically try non-operative management first. Typically consists of a brief period of rest, physical therapy, anti-inflammatories. Oftentimes we'll do a corticosteroid injection in the subacromial space to decrease the inflammation, decrease the pain so that they can get in therapy and actually start moving again. Surgical treatment is typically reserved for failed non-operative management, obvious full thickness tears. A lot of times in a work comp patient, if there's an obvious injury that caused the rotator cuff tear, we're not going to waste time with non-operative management. We're going to recommend repairing it and getting them back into the workforce. So largely the notion of arthroscopic versus open rotator cuff repair is probably a bit historic at this point. I think most of us now do pretty much only arthroscopic repairs. The advantages are obvious in that there's smaller incisions. I would argue that the visualization is far superior. It's almost counterintuitive. You think you have a big incision, you'd be able to see better. That's just not the case because you, with a scope, you can see further medial and under the acromion. You can do the releases that you need to do sometimes if there's a chronic tear or there's evidence of lysis or evidence of adhesions. Improve range of motion because there's less trauma to the deltoid. And from an objective standpoint, it results in earlier return to work. Here's a couple of pictures. The one on the top left is an open rotator cuff repair. And you can see that's a big hole. You can see the deltoid being retracted there. There's a lot of trauma to that deltoid, a lot of pain. And quite honestly, you can see the rotator cuff where it attaches, but I would say through these little incisions here in the arthroscopic, you can see much better. Up on the top right, that's what we would consider like a mini open repair, if you've ever seen that. You see a much smaller incision. But again, I would argue that you can't see a lot of what you need to see through that small incision. Here's an MRI showing what we commonly see is like a partial thickness tear. This one here on the left demonstrates, again, the supraspinatus tendon. The tendon on this particular MRI imaging should look black, and you see this white running through this. This is what we consider like an interstitial tear, sometimes almost like a tendonitis type of picture. But you can see that the attachment is actually still there. This one on the right demonstrates, again, the normal rotator cuff tendon, but you've got this white signal on the undersurface. This is what we would consider like an undersurface or a partial articular sided rotator cuff tear. What that looks like through the scope is, again, here's your humeral head. This is your biceps tendon. Biceps tendon is coursing through the shoulder. This is the undersurface of the leading edge of the supraspinatus. You can see that there's some mild fraying there, but overall the attachment is still intact. There's no retraction. And those we typically just kind of clean up with the shaver. Again, another example of a partial articular sided tear and shaving it up. Typically, if the tear is less than 50%, then we'll just kind of debride up the part of the tear that's frayed or torn and not do a formal repair. Here's an MRI of more of a full thickness type of rotator cuff tear. You can see that so again, the supraspinatus tendon's coming in. This time we're seeing that the entire attachment is off and that the supraspinatus is sitting back here when it should be attaching here. Again, another picture of this. Now these tears aren't significantly retracted, but sometimes we'll see tears that are retracted back to the level of the glenoid or the shoulder socket, which is here. Again, what that looks through the scope, here's your humeral head. In contrast to the normal MRI here, you can see that there's a fairly obvious hole in the rotator cuff tendon, supraspinatus. Again, another example of a rotator cuff tear. Again, this is looking from the subacromial space, and we should not be able to see into the shoulder joint. Here's the shoulder socket of the glenoid. Here's the humeral head. This cuff of tissue should be attached out here, and we should not be able to see into it. So there's lots of different ways to repair rotator cuffs. Single row versus double row, all that means whether or not there's one row of fixation versus 2 rows of fixation. Personally, this is the technique I use the most, which is placing 2 anchors medially that are cannulated and threaded with sutures, threading those sutures in through the rotator cuff, and then basically performing this sort of like crisscross box technique of then fixating it with a lateral row. Basically what we're doing is restoring the anatomic footprint of the rotator cuff back down to the greater tuberosity to allow that tendon to heal. Here's some pictures of that process being done. Again, your rotator cuff tear at the top. This is putting the anchor in. Those anchors are typically threaded with what we call a fiber wire or some sort of super strong non-absorptive suture. We then weave those sutures through the cuff of tissue here, and then pull it back over to its footprint and attach it with another lateral row of anchors. So again, going through that process one more time, punching it, putting your screw in, weaving the sutures through the tendon, and then reattaching it out laterally. Here's an example of a rotator cuff tear. You can see that the biceps is in the background. And what you've done is now restored that anatomic footprint, pulling that tendon back over to the greater tuberosity. Post-op rehab, this kind of differs between surgeon, but generally speaking, we'll put patients in a sling with an abduction pillow for the first 6 weeks. How aggressively we rehab those first 6 weeks kind of is physician dependent. Meaning if you look at some of the studies, they would tell you that you can not even do therapy the first 6 weeks and it ultimately doesn't matter in their range of motion. That makes me a little nervous. If anything, I feel like rotator cuff repairs, especially in the work comp patients, tend to be on the stiffer side. So I will typically get people moving passively right away, unless it was just a massive tear or there was a lot of retraction or we had to do a lot of releases or it's a revision. Sometimes I'll have them sit for the first couple weeks and not do much. The first 6 weeks of passive motion are typically then followed by active assist motion and then transitioning to active motion, and the strengthening where they really get their strength back is in that final 3 to 6 months. Do you guys hold your cuffs still the first 6 weeks at all? Yeah. So here are some things that go hand in hand with, or again, reasons why a rotator cuff repair may not heal. Age, they throw around the age of 60 or 65 as being 30–40% of non-healing rates with rotator cuff repair. Size of the tear, atrophy, or basically a chronic tear that's retracted. Smoking, osteoporosis, diabetes, and hypercholesterolemia. You guys probably see surgical requests for rotator cuff repair come along, and there's all this other stuff listed like subacromial decompression, biceps tenodesis, distal clavicle resection. You're probably thinking to yourself, what's this guy doing? Is he trying to make a bunch of money, or what's going on here? I didn't see any mention of these things in the MRI report. Well, all these things contribute to the overall pathology of rotator cuff tears, and oftentimes are present in people that have rotator cuff tears. And I guess treating all of them as a spectrum of disease is ultimately in my mind is the goal of like having this patient have a good outcome and not having the rotator cuff tear heal, but the patient be complaining of biceps tenodesis down the road or continuing to complain of impingement or things like that. So oftentimes we look at a rotator cuff tear and approach it as a whole spectrum. Here's an example of I guess the notion of impingement, if you're wondering what that is. This is kind of a schematic on the top. You can see, again, the shoulder, the glenoid, greater tuberosity here. You've got the acromion on top. The rotator cuff is running through. As you abduct the shoulder, oftentimes, this position or this position, what you're doing is you're driving the greater tuberosity up against the acromion, and basically that supraspinatus tendon is sort of getting pinched between the two bones. Now, as we age or over time with trauma, you tend to develop a little bit of, I hate to call it spurring, but you kind of bony deposits on the undersurface of the acromion, which makes that more likely to happen. So oftentimes for two reasons. Number one, to prevent the impingement, but also to make it easier to repair the rotator cuff. Because quite honestly, working in this space, and if there's a big bone spur there, it sort of limits how much we can do. So oftentimes we'll do a subacromial decompression, acromioplasty, which is where we're taking the spur and we're using a burr and we're basically coplaning it down to open up that space so that mechanism of impingement then won't happen. Because the last thing you want to do is repair the rotator cuff and have the person abduct the shoulder, and every time it's beating up against your repair. If that makes sense. Again, another example of a subacromial decompression. So you probably see Mumford or distal clavicle resections too. Here's an X-ray of AC joint arthrosis. It's sort of the same concept, but oftentimes as people age, they're prone to getting arthritis in the AC joint. That also can basically contribute to impingement of the rotator cuff, because that spur on the inferior surface of the AC joint is basically digging into the supraspinatus muscle and supraspinatus tendon. So again, it's one of those things, if you're there and it's there and you think it's contributing to the overall pathology or how they're going to do with the repair, oftentimes we'll do the distal clavicle resection. Here's an example of an AC joint. That probe is basically showing you there's no space between the distal clavicle and the acromion. And so we'll just take the burr, similar to the acromioplasty, and open that space up. Finally, also the biceps tenodesis, I tend to do almost with all rotator cuff repairs unless it just looks perfect. But the reason for that is the biceps attaches at the top of the glenoid. It enters the shoulder or leaves the shoulder through the rotator cuff interval, so between the subscapularis and the supraspinatus tendon. And you can see oftentimes with rotator cuff tears, especially involving the leading edge of the supraspinatus, it's right there. It's involved in the whole mechanism. So you repair the rotator cuff A, you risk entrapping that biceps in your repair. And also, you're repairing the rotator cuff, and now you're worried about friction of that biceps running past your repair. And quite honestly, it's one of the, reasons for failed rotator cuff repair is that people have bicipital pain even after their rotator cuff might heal. And therefore, most people now are biceps killers, I would say. Are you guys biceps killers? Yeah, so what that means is we're just eliminating that as a source of pain from the shoulder. And so there's lots of different ways to tenodese. Tenodese is just a fancy term for reattaching the biceps in a different spot. So what I'll do is I'll cut the biceps from the shoulder. Other reasons, here's an example of a subscapularis tear. So a subscapularis is one of the other rotator cuff tendons. And you can see the subscapularis is this tendon here. It should be reattaching here. Again, you see it here. This is the biceps. The biceps should be sitting in this groove right here and right here. If you see a subscapularis tear, what that does is it allows the biceps to subluxate into the shoulder joint. So when you repair a subscapularis, it goes hand in hand with the biceps. The biceps has to be tenodesed because it's dislocated in the shoulder joint. Sometimes it's more subtle, and sometimes it's not that the biceps is torn or it's detached or there's rotator cuff tear, but sometimes your biceps just looks like it's irritated. And if you think it's contributing to the pathology and their exam correlates, oftentimes we'll tenodese it, again, to eliminate it as a reason for having pain going forward. So that's a shot of just some scissors, and there we're just killing the biceps. And then lots of different ways to tenodese. This is the method I use. I make a small incision in the axilla. It's called a subpectoral tenodesis. It's a small incision. I reattach it underneath the pec tendon. I like this technique because it's, in my hands, it's just reproducible, and I'm getting it out of the bicipital groove and out of the shoulder completely. Other people will do it through an arthroscopic technique, which is equally as good. So again, we talked about this. Again, for age, each year over 60, the risk of re-tear or non-healing increases by 1%. For each centimeter of tear, the risk of re-tear increases by 2 times. The only thing I didn't mention in the previous reasons for failure is that big gorilla at the bottom, which you guys are probably familiar with that, and that's work comp, actually. And if you look at lots of studies in our literature, this is a review article. They looked at 28 studies, rotator cuff repair. And again, in 27 of the 28 studies, there was a strong correlation between work comp status and poor surgical outcome. Again, another article. Do outcomes differ after rotator cuff repair for patients receiving workers' compensation? So they had 141 rotator cuff repairs, 36 of them were work comp. And at 6 months, the work comp patients had worse pain, worse function, and worse range of motion. Is that because the surgeons just kind of sucked that day, or no? Yeah. So why do we repair rotator cuffs? Well, in the work comp patient, usually it's obvious. It's because they can't lift their arm or they can't function. This is an X-ray. Again, the normal shoulder X-ray, shoulder socket even. Over time, what happens is if you lose that, if that rotator cuff tendon tears and you lose that depressor of the humeral head, over time what happens is you'll get superior migration of the humeral head, which you see on the right side. Again, here's kind of a schematic of the same patient. Over time, the changes that occur. You start with a little arthritis here, spurring, and you can see that the superior humeral migration just gets worse and worse and worse until there's complete arthritis and erosion of the acromion, and now you have what's called rotator cuff arthropathy, which amounts to shoulder arthritis. How that manifests itself clinically, and this is one of the things I always look for in a rotator cuff or a work comp patient. This can clue you into whether or not this was truly an acute injury versus something that's been there for a long time, and that's atrophy around the scapula. That would tell me that this is not a new rotator cuff injury. The other way to look is on an MRI. This is the supraspinatus sitting in the fossa here. It should look like a nice fat steak here, nice and muscular. But over time, if a rotator cuff tendon's been torn for a long period of time, it'll start getting fatty atrophy until the point where you see that there's not much muscle left. It's basically it's turned to a fatty steak. Just another, I guess, study showing the value of rotator cuff surgery, especially in the young working patient. And this should make you feel better about approving rotator cuff surgery and the money you're spending, and that you're saving society so much money. So here's a couple cases. So here's a 47-year-old dude. He just fell off a truck. Seems like an acute injury, no antecedent shoulder pain. MRI shows a 2-centimeter full thickness tear. Can't abduct his arm. So this is pretty clear cut. I mean, this is a patient where they shouldn't get a bunch of pre-surgery therapy and injections and yada, yada, yada. This is a patient probably not going to get better without surgery. And I would argue to just sort of expedite the process, get them back to work the fastest. Again, here's a picture of rotator cuff tendon and repair here. So, second case, along the lines of the previous, this is a Walmart greeter. He's 67. He slipped on the ice. Now all of a sudden he says he can't use his shoulder when he could before. And his MRI, similar to the one I showed earlier, atrophy, fatty infiltration. That's his X-ray. So you can see there's clearly some arthritis already present. So what do you do with this guy? Here's his MRI, atrophy. That's what he looks like. So clearly you're seeing signs that this is not an acute injury. And so this is, again, a guy that I'm going to recommend therapy, injecting him, try to get him as functional as possible. Ultimately, he's going to need a reverse shoulder, total shoulder. But, typically I'm going to tell him that workman's comp is not going to pay for that. And finally, I mean, here's like as common as anything. Here's a guy who does a chronic repetitive overhead work all the time. And for the last 3 weeks, his pain's been worse. No real definite injury, but can't paint now, can't work overhead because it hurts. His exam, you know, he's got signs of impingement, he's got some weakness. His MRI basically shows, you know, his rotator cuff's not completely torn, there's a little bit hanging on, but there's a lot of signal. You know, this is probably the most common guy that we see. It's just kind of he does a chronic repetitive overhead job, and finally just decided to give or to cause him pain. So this is a guy I would try non-operative management on. I'd try an injection. I'd probably try therapy, anti-inflammatories. And I'd say it's probably 50-50 whether or not he gets back to work without needing surgery. And that's probably, looking at that MRI, that's probably one that's gonna need to be fixed if we get in there.